And thank you, the President of the Diabetic Foot Society and the local committee and chairman for the invitation to speak here. I really appreciate the opportunity to open up my discussion and presentations and look at basic wound principles. And we will continue to focus throughout your day here and look, and we've had great discussions about dressings and materials. But again, the common theme from the speakers talks about the cause of the wound, the cause of the wound. And this is what I'll spend a fair amount of time looking at, the cause of the wound and how we have made efforts now really to address this cause of the wound. While we realize that dressings and materials are very important for the wound environment, we have to address the underlying cause in order to be successful. For disclosure, I am a consultant for KCI and Acelity as well as Integra. So we face this situation often. In US and India, with our rates of diabetes, we face this situation often where we have a presentation of a patient who's had a severe diabetic foot infection. We've operated, we've fixed the infection, and now we use our advanced healing modalities, negative pressure therapy, hyperbaric oxygen, address the wound, appropriate dressings, and in 12 weeks, we have wonderful healing. This is always a pleasure to show this photo and show this success. But does anyone see a problem with this case? In a young patient who maybe is not going to wear prescriptive shoe wear, what is going to be the problem long-term for this patient? We'll have reulceration, and we'll have reulceration underneath the second metatarsal head. So as challenging as this is, we have now started focusing more and more in our practice at Georgetown on functional amputation. So as much as it is a victory to save 4 of the toes, in a young patient with forefoot deformity, equinus, working, active, who's not going to wear prescriptive shoe wear, this patient probably needs more of a midfoot amputation rather than the first ray. So this comes from understanding the gait cycle. And if we're going to understand wounds in the diabetic foot, we have to understand the gait cycle and the cause of these wounds, which is repetitive, moderate pressure from walking. Some wounds come from pressure from bed rest and decubitus ulceration. Some wounds come from acute trauma from stepping on a nail or having a rock injury to a shoe or a foot. But most diabetic foot wounds come from moderate, repetitive pressure from walking. So we have to address this walking. No one walks perfectly. We could have everyone here come up on stage and walk for us, and we could find a diagnosis for everyone in the room. No one has a perfect gait. But the reality is that our patients with diabetes, this minor imperfection in gait becomes a major complex problem because of neuropathy, because of vascular compromise, and because of immune compromise. So these minor gait abnormalities become a major factor in wound complications to the plantar foot, particularly the forefoot and the midfoot. So we use plantar pressure assessment and we use technology to look at these individuals and to assess these individuals, but realizing that this plantar pressure assessment, so an in-shoe pressure analysis system, very valuable in the clinical environment, is difficult because it's cumbersome, it's expensive, it takes a long time, not something we use routinely. But if we did use it routinely, we'd be able to have success like this, because we'd be able to identify that shoes and the inserts have properly offloaded or removed the pressure from the area of concern. So if we look at this area here, this is a patient without ulcer, no wound on the foot. But we can see where the wound is going to be because we can see how high the pressure is from the gait abnormality and from the foot structure complications for this individual. So this individual will have an ulceration in this area, but we've taken and prescribed the appropriate inserts. And if you see here, left foot, right foot, we have total contact surface now. You can see how much more of the foot is bearing weight than is initially on the left-hand photos. And now we have distributed that pressure, we have relieved the ulcer risk, and we have succeeded in ultimately healing the wound before it ever occurred. This is an area where great emphasis needs to be placed. It's a great challenge. This is probably the hardest area, much harder than picking out the right dressing for the patient. Because here you have to convince a patient who doesn't currently have a foot wound of how they're going to work with you to prevent it. So let's talk a little bit about surgery. Diabetic foot surgery, which is going to be covered in this meeting by myself and others, is an emerging science, an emerging element to understand how we can address the mechanical problems of the foot to get better function and decrease wound healing complications. So the key goals of diabetic foot surgery are, number one, to reduce the pressure. We could stop there, that's probably enough. But number two, we want to prevent ulceration and amputation through reducing that pressure and balancing out the mechanics. We want to increase or improve their function, ultimately returning patients to work or to home activity. And then finally, because these patients were failing appropriate offloading or shoes or inserts, the ultimate goal of surgery should be to return them to proper accommodation or be able to wear shoes again. So we term this prophylactic surgery in diabetic foot. This is an area where I dedicate a lot of my practice and a lot of my attention to this because I work in practice at Georgetown with Dr. Christopher Attinger. And in 2004, when I joined the practice, Dr. Attinger is wonderful at wound healing, wonderful at diagnosis and treatment and management of diabetic foot wounds. But the area that he needed me to come in for foot and ankle surgery was to address the mechanical complications, so the underlying cause of the wound. And we can do that at the time of the wound, or we can do that at the time of the initial pressure. And we'll talk about some of that, because the more we can address this at the time of the initial pressure, then the more benefit we're doing, because we're actually preventing these wounds from occurring. So if we look here, obviously patient selection is key. There is a very narrow segment of the diabetic foot ulcer population that can safely undergo corrective foot surgery. This is not something that's going to be prescribed for every one of your patients with a diabetic foot ulcer complication or a diabetic foot complicated pressure area. Next is appropriate preoperative screening. You saw earlier a presentation talking about high care and using the transcutaneous oximetry. Similar to addressing a wound complication, when we're screening our patients for diabetic foot surgery, we're doing these type of tests and this type of non-invasive or even angiography to make sure that we have sufficient blood flow for healing. If we have insufficient blood flow when we make an incision, we all know what happens there, and that's going to be more gangrene. We have to understand that these procedures are evidence-based and understand that what you are doing makes sense mechanically and by the literature and academically, that this is the right thing to do for your patient at the right time. And then finally, we need a team approach. This is one key area in the diabetic foot where you cannot approach this alone. You must have a team. You must have providers who are of different specialties who can assist you and the patient when complications arise, because they will arise. You will have complications. So importantly, we have to identify the foot type. And this is a great example of not having blinders on when we address wound care. Because I love to talk about dressings, I love to address appropriate debridement, and we're going to have a whole talk on wound debridement. No doubt that when someone comes into your office and they have a wound, you're going to focus immediately on the wound. But in reality, what we should be looking at is what caused that wound, and coming all the way down to what is their foot type. Do they have a flexible foot or a rigid foot? Do they have a pes cavus or high arch foot, or a pes planus, a low arch foot? If we don't know what foot type they have and we don't know what caused the ulceration, then it makes no sense that all we're going to focus on is treatment. Because that's going to win a victory in a very short period of time, but they're going to be right back in your office or someone else's office with a new wound and a new infection and a new amputation because you never addressed the actual foot type or the underlying etiology. So that is my greatest challenge to you, is that although we focus on wounds and we focus on the great technology that we have in wound care, and this is great success that we have now in these machinery and these dressings and these medications that can and should be used. But we have to at the same time be thinking about the bigger picture of what caused this. For example, this patient. You look at this foot type. This is a rigid foot type with a severe hallux valgus or bunion deformity. You have a plantar flex metatarsal, prominent sesamoids. There was a callus here for years. Then the callus became a bleeding callus. Then the bleeding callus became a small ulcer. And then the small ulcer became a diabetic foot infection that caused an amputation. All of that was preventable if we addressed the actual foot problem. We knew this was coming 10 years ago, and no one addressed it. So that's the biggest challenge, is to address these early and often and try to move from wound care to diabetic limb salvage, meaning that we're gonna comprehensively treat this patient. We're gonna fix your wound today, but then next month we're gonna do the surgery to fix your bone and your tendon problem so you don't have another wound. And we're gonna address your other foot too, where you've never had a wound. And we're going to do surgery there. And we're going to lengthen your Achilles tendon so that you can wear shoes and not have an ulcer on that foot. So this example is just the routine for diabetic foot. The patient comes in. We have many of our patients now into a method of preventive care where they will come in every 3 months, every 6 months, every 12 months for a diabetic foot examination. No wound, no pain, no problems. But they're sent by their primary care doctors, and this is where we're slowly starting to establish a true comprehensive diabetic foot program where patients are actually coming to us before they have a wound. Maybe they've never had a wound. This is the example of where you, as their provider, need to realize and say, hey, you're doing great, you're following up, you're making your appointments, but the shoes and this callus debridement are no longer helpful. You're having problems to the degree, such as what you see here, where this simple callus has turned into what? This is high pressure, high gait pattern abnormality with an underlying ulceration. So if you're going to take your scalpel out and debride this callus now, but you see that dark brown black pigmentation, that's blood, and that means the pressure is now high enough to have formed an ulcer and formed a wound, and they have a diabetic foot ulcer. Even though it may not be open, it's going to be open by the time you debride the callus. So offloading, we talked about in previous discussion. There are 4 components to offloading. We're going to spend good time at this meeting talking about each one of them. The first is debridement, and we'll talk about that shortly. The second is acute pressure relief, which was discussed earlier with total contact casting being the best method, and then removable cast walkers would be the second best method. Next would be long-term accommodation. So these same patients, again, we talked about needing long-term care. If we don't prescribe something long-term like a shoe or an insert, then we have just fixed the immediate problem and we've not done anything to address them long-term. And then finally, if the shoes and inserts are not enough, then you have to realize this patient needs surgery. We're going to lengthen your Achilles tendon. We're going to shorten your metatarsal bone. We're going to take out your sesamoid, whatever it may be. We're going to operate so this doesn't happen again and again and again. So let's look at a case study example of just what we're talking about. This is a patient with diabetes, has never had an ulcer. Diabetes, neuropathy, foot deformity. If you follow the University of Texas classification system, we'll talk about it briefly tomorrow, but many of you probably use it already. This classification system for this patient is University of Texas Foot Risk Category 2. And if it's University of Texas Foot Risk Category 2, these patients are 12 times more likely to ulcerate than if they were in Category 0. High risk for ulceration. So this patient has the deformity, this patient has the neuropathy, this patient has early vascular compromise, and the shoes and the inserts are no longer working. So if you look at the main problem here, there is equinus, there's neuropathy, and you can see the contracted toes. These contracted toes are now causing a prominent metatarsal parabola. You can see this area of prominence here from these contracted toes. This is very simple surgery that in someone without diabetes would be having terrible pain, would come to the foot doctor and say, I need surgery to fix my toes. But because they have diabetes, no one complains about pain because they have neuropathy. But they are significantly more important to address these toes than to the painful patient. Because you address these toes, you're going to prevent an amputation. You address the toes of a person who's having trouble wearing the shoes they want to wear, you've made them more comfortable, but you are not dealing with a potential amputation risk. So here's where we are now. Dorsal incision, hammer toe correction, very straightforward surgery. This is outpatient, takes about an hour of surgery to do. Recovery period is 2 to 4 weeks. They can be walking and ambulatory throughout the recovery period. This is a fairly easy surgery to recover from. And if you look now, remember the ball of the foot was so prominent, and now the foot is flat. This is what we're trying to achieve for these individuals. Postoperatively, you can see the calluses that were on the plantar aspect of the foot are now becoming thin and falling off the skin, and at 6 months after surgery, there's no more callus. Because you've addressed the underlying etiology, you've addressed the mechanics, and you have changed their foot type and their gait pattern. Now let's switch gears to a much more difficult wound site. That's an easy one. This is a hard one. When someone comes in with a heel ulceration, this is perhaps the most highest risk for amputation and limb loss. because these individuals have very few options. Casting does not usually work for heel ulcerations, because if they're walking on it, the pressure is mostly going to be in the heel. So these are very, very difficult wounds to heal. We are aggressive on these surgically, and we try to be aggressive early, because if you wait and you just use wound care for heel ulcerations, you're going to have a very high risk of osteomyelitis. You're going to have a very high risk of infection and loss of limb. So for these individuals, we go in aggressively and we do surgery to elevate the calcaneus. This was happening because of a gait deformity and a mechanical structural deformity, because this patient has such a high calcaneus. The inclination angle is very sharp, therefore all the pressure is being focused in a small area of the plantar calcaneus. This can be addressed. This should be addressed with surgery and hardware to address the calcaneus, and you can see the healing. So here's an example of what we're doing. We're actually taking a wedge of bone out of the calcaneus through a lateral incision. So you have this high pitch calcaneal angle with a ulceration underneath this focused point of the calcaneus. You can see here lateral extensive incision similar to what's done for a calcaneal fracture. We take a large flap, elevate that off so that we don't create ischemia or gangrene through the incision. We use the angiosome principle and stay along the glabrous junction of the skin here. You can see the plantar foot and coming up the back towards the Achilles. So this is Achilles tendon. This is calcaneus and lateral foot. Here's the ankle. So here's the same patient. We've made our incision. We've taken out a wedge of bone. We've flattened the calcaneus. And we fixed the ulceration. So here another example, switching back to the forefoot. Much more common, of course. So these are some of the everyday wounds that are going to be waiting for you when you go back to your office and your hospital and your clinic. And if you look at this differently now, rather than just diagnosing the wound, everyone in here can pretty quickly diagnose this patient has an ulcer. But the hard part is what caused the ulcer? Why is that ulcer there? And why is it in this particular location? And what can I do as their provider to work with the team and address that cause of the wound? So we really, in the select patient who has repeat ulceration, who has severe foot deformity, we've gotten very aggressive now surgically to address that deformity. So lots going on here for this patient. 40 years old, diabetes type 1, advanced neuropathy. This patient is numb from the knee down, cannot feel any sensation or pain, has chronic ulcerations underneath the first and fifth metatarsals. This slide shows why this patient has the ulceration. When you take the time to do the foot exam, find out what their foot type is, this patient has a very high arch pes cavus foot type that's placing all the pressure on the metatarsal heads, a little bit of pressure on the calcaneus, but mostly on the metatarsal heads, and it stays there throughout the gait pattern. So when they're stepping off the ground, all that pressure is on the ball of their foot, and it's all underneath the first and fifth metatarsals. The best shoes, the best inserts, all the debridement, wonderful dressings, nothing's going to fix this long term. You might fix it short term when you have them stop walking, but as soon as they return to work, as soon as they return to their family, the wounds are going to come back. So we address this with surgery, and you can see here addressing, this is the extensor hallucis longus tendon being dissected out and cut distal to the hallux interphalangeal joint. Here's the tendon now folding back onto itself. Running that extensor hallucis longus tendon as a transfer into the first metatarsal. So we're detaching this deforming force that's been causing ulceration, and we're turning this tendon that was a deforming force into a corrective force. By transferring this tendon, it now lifts up the first metatarsal and therefore takes the pressure off, long term. This is not short term. We're not having to take out the bone. We're not taking out the metatarsal head. We're not taking out the sesamoids. All that is normal anatomy. The metatarsal head is normal. The sesamoids are normal. If you go take those out, you're just going to transfer the pressure to the second metatarsal. And then you'll end up with the very first slide that we saw earlier, where you have a transfer lesion. So we fused the hallux interphalangeal joint because we have detached the extensor hallucis longus tendon. The EHL tendon is no longer present, so we don't want secondary contracture from our surgery, so we preventively fuse that with a screw. And long term, you can see here at 2 months, we continue debridement, we continue good wound care, but now we have fixed the underlying deformity, so all of that technology can actually work. The metatarsal parabola, probably the most common mechanical problem that we see for our patients, is combining equinus, so tightness of the Achilles tendon or the gastroc with the ankle, with an abnormal metatarsal parabola. And again, we could examine everyone's x-ray here. I'm sure we could find something wrong with every one of your feet, with every one of your x-rays. No one has a perfect foot. And when you have diabetes and you have neuropathy and you have a partial amputation, now this third metatarsal becomes a major factor. When the second metatarsal was here, maybe it wasn't a big deal. But look how long this third metatarsal is compared to 4. Look how long this third metatarsal is compared to 1. The surface area between these two, much larger surface area here, much smaller surface area here. So there's a focus of pressure in a much smaller, tighter area. This has to be addressed. You're not going to win long term unless you go and fix this metatarsal parabola, and that's what we've done here. Small incision on the dorsal foot. We do an osteotomy oblique through the metatarsal head and neck. We slide the metatarsal back. Don't take out the metatarsal head. If it's not infected, try to preserve the anatomy. Fix the deformity, address the deformity, and fixate the fracture site that you've created. Now we have a nice even metatarsal parabola that forms an arch for active weight bearing. So this is about as basic as it gets in regards to mechanics and foot ulceration. This is probably the most common ulcer that I see at Georgetown, that I'm sure you see regularly in your practice. Plantar forefoot ulceration, patient with diabetes and neuropathy. So day 1, the patient comes in, we address, we diagnose, we get x-rays, there's no infection, blood flow is good. So we're going to begin debridement. And we're going to debride this wound, and we're going to apply appropriate dressings. And we do that for week 1, and we do that for week 2, and we do that all the way through to week 4. So we've got a granular, healthy wound. The dressings have worked. They've done their job. There's no more maceration. There's no more undermining. There's no tunneling. There's no exposed bone. But the problem here is that we now have a large wound that, according to Peter Sheehan and his work in diabetes care, the wound healing trajectory is flat. There's no wound healing. It's not getting worse, but it's flat. And if it's flat at 4 weeks, it's going to be flat at 12 weeks, and it's going to be flat at 48 weeks. So you know at 4 weeks, if you're not getting 10 to 15% healing from your debridement, your dressings, and your offloading, it's time to go back and re-diagnose, reassess, or retreat this wound with something different. You can't keep doing the same thing. That's not fulfilling your need and your duty to the patient with this diabetic foot ulceration. If they keep coming back to your office and you keep breaking out the same dressing kit and you've done it for 4 weeks and the patient's not healing, you need to do something different. You've either misdiagnosed it or you're not treating it appropriately, because it should be healing. If there's blood flow and no infection, the wound should be healing. So for this patient, when we went back and reassessed this patient, we discovered significant ankle equinus. The foot was in a permanent plantar flex position. The Achilles tendon had prior injury, was even tighter just because of diabetes, and now we have a situation that we have to address this. So we go to the operating room, we did a percutaneous tendo-Achilles lengthening, brief, safe surgery, outpatient, put the patient back into the same dressing, the same offloading device, and now we have healing in just 4 weeks. So this is the type of 4-week progression that we want to see. If you're seeing the other after 4 weeks, you've got either the wrong diagnosis or you've got the wrong treatment. Now you will have complications from doing these surgeries. You will have infections, you will cause some amputations, you will cause patients to have significant comorbidities or risk factors where they have other deformities that present. This is not perfect. We certainly have our share of complications, and here you can see a few of mine recently with terrible foot infections from these dorsal incisions. We try to do this safely. We prescribe antibiotics. We try to use sterile technique. But even with that, these are high-risk patients with immune compromise. You will have complications. But the key factor is to address the complications aggressively. Don't allow the complications to dwell and smolder and become worse and worse. That's how you end up with an amputation. When we have a complication like this that comes in, the patient gets admitted to the hospital, they get put on IV antibiotics, we go to the operating room that night or the next day, open everything up, take out all the stitches, take out all the hardware, and start over. If you don't do that, you'll end up causing an amputation. These are high-risk patients and they need aggressive management. Both of these patients, as you can see here, went on to do very well, but it was only after we admitted them to the hospital, opened everything up, and readdressed it aggressively. So don't be afraid to deal with the fact that, yes, you've had a complication, now we're going to address it. So one of our greatest challenges in the diabetic foot is that these procedures, which we now have to do partial foot amputations, lead to yet another amputation. So you can see the central metatarsal amputation caused this toe contracture, which led to another amputation. The first ray amputation caused a second toe contracture and second metatarsal ulcer. The midfoot amputation with contracture causes breakdown at Lisfranc's joint. And you can see here, this is clearly a non-functional amputation. We can't expect that we're going to try to save a miscellaneous toe or a portion of a foot. We have to get to a functional amputation level. Restore a parabola, get to an even foot, something that can be put into a shoe, something they can walk with and be productive with. Initially, in the first few decades of diabetic limb salvage and diabetic wound care, the statements were to preserve length, preserve length, preserve length. Well, if that's the rule that you follow, then this is what you're going to end up with, and that's a non-functional amputation. So preserving length is important, but preserving function has to come first, and then preserve length. Here again, my least favorite amputation is a partial first ray amputation, because the patient has the illusion that their wonderful doctor and their healthcare team have saved 4 of their toes. But in reality, if you look at this patient, these toes are already contracted, the metatarsals are already prominent, and there's significant ankle contraction equinus. This person will get an ulcer. It's a matter of time where that's going to break down. And if that's what you and the patient agree upon, then that's fine. But the other alternative is to either address these toes and go and surgically straighten their hammer toes so that you take the pressure off the metatarsal parabola. And I do that very often and very aggressively, combine it with an Achilles lengthening and a hammer toe correction. Or you need to talk to the patient about having a transmetatarsal amputation now rather than waiting. Another example, we cannot expect that wound healing and dressings and negative pressure therapy and hyperbaric oxygen alone are going to succeed. This will not have a happy ending if that's all you're doing. You have to address the mechanics. You have to realize that this person is walking on a horribly imperfect foot. You may have fixed their blood flow, you may have fixed the infection, but if you don't address the mechanics, there's going to be a big problem. And then here again, this is a remnant 5th toe. This is not a great toe, this is a 5th toe in a situation where everything else is gone. So 5, 4, 3, 2, 1, everything's gone. This is really inexcusable. You can't do this. This has to be at the time that you were performing the infection and the amputation. You've got to create an even parabola again. This is not a functional foot. Even in someone without diabetes, this is going to fracture and break down. Keep in mind that nothing beats a well-placed split-thickness skin graft. So if we look at some of the other technologies that are going to be looked at here, include stem cells. So I wanted to give a basic introduction or overview there, but don't be distracted by the fact that still the best skin, the best healing comes from the patient's own skin. And if you can get some graft from the thigh, then that's a wonderful, great opportunity, but this does not come without its own complications. And you can see here, this patient is running out of space to give donor graft now. This is too much grafting in a high-risk patient. So we have a lot of products that are available. These are called cellular and tissue-based products for wounds. Many of these will be discussed and looked at here. These come in either living or non-living form. Some of the newest technologies for these include amniotic membranes, and I'll look at some of that later on in some of our other discussions. These have been highly successful. Larry Lavery and others have published on this very recently, looking at these amniotic tissues used as stem cell donors onto the wound site, making a huge difference. In this particular study, Dr. Lavery looked at 50 patients who received graft and 47 that received standard of care. The graft patients, 62% healed within 42 days, and the control group, only 21% healed in a 70-day period. Probably the most interesting part about this study was a closure in Grafix patients who first failed standard of care. So of these patients that did not heal in the control group, they had a crossover group. And these patients changed from just getting moist dressings to getting the amniotic stem cell tissue. And when that was applied, 80% of those patients became healing patients. So this helps to remove some of those factors of the underlying disease and the underlying mechanics to separate the control group from the active or Grafix group. We've had a lot of experience with Integra at Georgetown. We're using this for a lot of our surgical wounds, and you can see here in patients who were all deemed necessary for amputation initially, in patients that we separated into low risk versus high risk. We published on this in Plastics and Reconstructive Surgery. We found an 83% salvage rate in persons who received the Integra who were listed as low risk for amputation, and a 45% salvage rate in patients who were deemed highest risk for amputation. The algorithms and the overviews here are to understand the reality that you have to first determine the etiology of the wound. We have to perform debridement and cultures. If those cultures remain positive, then we keep debriding the wound site. And if the cultures are negative, then we move on to realizing that these patients can get grafting and everything. Just one more minute. I'm almost done. We're good. Finally, no problem. We're good timing. I'm wrapping up. So the offloading of biomechanics, realizing that these patients who have these significant foot deformities, we have to again realize that dressings, debridement, offloading, these are the pillars and basics of what we need to start with, but make sure that at the same time you're actually addressing their underlying problem. And if you do that, you're going to provide the comprehensive care that these patients need and deserve when they come to see you and trusting you with their health care as a patient. So these are some of the deformities that we talked about briefly. Much more to discuss here and will be discussed during the meeting. I want to emphasize, and we'll see a video later on in one of my discussions about this, but the tendo Achilles lengthening is just a simple, low-risk, high-benefit procedure that patients, I think, need to have more often. I think this is probably the most underutilized beneficial procedure in the diabetic foot, particularly for a forefoot ulceration. These individuals can have huge benefit from these procedures, and I would challenge you that this is something we should be incorporating much more often. If you look here, after the procedure, unable to dorsiflex, postoperatively, dorsiflexion 10 to 20 degrees. Much of what we have just talked about focuses on the prevention of recurrence. And recurrence, although very common even with corrective foot surgery, we can do much more to prevent recurrence. And that's something that I want to challenge you as an audience to do, is to focus not only at this meeting on the need for wound care and the need to address what's in front of you, but the bigger picture of realizing what caused the wound and how can you provide a team for these individuals at your institution, in your location, to give them the best chance of long-term success. Thank you very much.
I think over the years, as I keep listening to Steenberg, it gets interesting day by day, as usual, par excellence. So treat not just the wound, but what caused the wound. I think perfect demonstration of treating the causative factors and the biomechanics. One or two quick questions for Dr. Steenberg, because he's going to be around for the whole day, and he's going to come back to give us more lectures. So one or two quick questions now, and the rest to follow.
Hello, I'm Dr. Madhu from Coimbatore. In patients with equinus deformity, would you prefer a tendo Achilles lengthening or a gastrosoleus recession?
Great question. So gastrosoleus versus tendo Achilles lengthening. In diabetes, I much prefer the tendo Achilles lengthening because the deformity and the contracture and the glycosylation is in the tendon. You're addressing the source of the problem if you go to the tendon. If you do a gastroc recession, it can be safer, less risk for rupture, less risk for heel ulceration, but much less benefit. The physical dorsiflexion that you get from a gastroc recession is much less. So I prefer the tendo Achilles lengthening. I get better ankle range of motion. However, there is a learning curve to the procedure. And initially, in my early practice, as is common with anyone else, you tend to be over-aggressive and you over-lengthen. And that can happen easily with the tendo Achilles lengthening, and that's where we read about rupture rates and heel ulcer rates from these lengthenings. Gastric recession does not have that risk. So if you're concerned about the risk of heel ulceration, gastric recession is safer, but not as powerful.
Sir, what is the success rate when you are trying to save the metatarsal head, as you discussed in your previous slide?
So trying to save the metatarsal, so talking about a partial first ray amputation. So partial first ray amputation in younger patients is a horrible procedure. Because again, you and I have, and the patient has the illusion that you've saved 4 out of their 5 toes, but in a patient who's 40, 50, 60 years old, they're going to be way too active for that deformed foot, and they're going to re-ulcerate. A partial first array amputation to save the metatarsals in someone who's 70, 80 years old works very well because their activity level is going to be very low. But in someone with a high activity level, a first array amputation, 6 months to 2 years has an 80% rate of re-amputation.
Okay. And second metatarsal, you save the head of metatarsal and fix it again.
Yes.
So in that case also, what is the success rate? In
So in the metatarsal parabola correction, or this is a while osteotomy done for the metatarsal, this has maybe a maximum 5% complication rate from infection or displacement or non-healing. So very low complication rate because there's very good blood flow to that area. It is a stable osteotomy that has the soft tissues remain intact and has a very low complication rate. So the metatarsal osteotomy is very successful in the salvage.
Any particular contraindication not to do that procedure? Like
Any
infection?
particular fixation?
Any particular contraindication?
Contraindication. So if you, first off is blood flow, and the second would be it's best, if possible, to heal the ulcer first. So if they have an ulcer, we want to cast them, offload, non-weight bearing. If you can operate with a closed skin envelope, your infection rate, of course, goes way down. So that's the main complication. But these patients can have a non-union where the bone will fail to heal. But in this area, it's really not, it's not a major, even if it goes to a non-union, it's not a long-term complication.
Thank you, sir.
Sure.
Thank you very much, sir. We'll be looking forward to more discussion with you personally over tea and over lunch and probably more exercises in the